but I just wanted to take this opportunity to just introduce our main speaker, Dr. Megan Budge. Dr. Budge is a fourth-year anesthesiology resident at the University of Washington, and she's in the last week of her point-of-care ultrasound elective. She's going to be joining the faculty actually at Harborview Medical Center next year, and she'll start in September as an acting assistant professor. She's got an interest in global health and in providing medical care in under-resourced areas, so it's very fitting that she's taking the opportunity to present here at the Global POCUS Collaborative. Dr. Budge, thanks so much for joining us this morning, and I'm just going to hand over the reins to you.
Thank you so much, Dr. Nickervon, and awesome to see the who's who of the department here. Thank you everyone for joining. So I am in my last week of my point of care ultrasound elective, and I really wanted to take this elective because as I look forward to going into starting my anesthesia career, it's clear to me that ultrasound is a really important part of the future, and especially when considering all of the opportunities to use it in a global health environment. It was something that I wanted to have a lot of practice with, so I'm very grateful to have this opportunity and excited to share all of these cases with you. So I have 3 cases to share with everyone today. And we'll go ahead and start on this first one. So this is a 55-year-old female with a history of fibrotic hypersensitivity pneumonitis and newly diagnosed non-ischemic cardiomyopathy with heart failure with reduced ejection fraction, who was admitted to the hospital with cardiogenic shock, which has now resolved. And when I met her, she was presenting for placement of a permanent pacemaker. And this is our first view of this patient. And just to make sure everybody's awake this morning, somebody want to shout out which view this is that we're looking at?
Subcostal 4, maybe?
Yes, exactly. So this is our subcostal 4-chamber view. As we can see, the marker is on the right side of the screen here, so that tells us that we're in a cardiac preset here. We have the ventricles on the right side of the image, atria on the left side of the image, consistent with this subcostal 4-chamber view. We do have adequate depth here to assess for effusions, which is good. So, and we also have view of all 4 chambers in this view. As far as findings go, what do folks think about effusions? Any effusions that we can see here?
I don't see any effusions.
Yeah, we didn't think so either. So no clear pericardial or pleural effusions in this view. I think what really stands out to me about this image is the ventricular function. So oftentimes in this subcostal 4-chamber view, usually the RV actually appears a bit diminished if it's lined up appropriately, like in this view. And we still have a pretty prominent right ventricle in this view. So potentially an enlarged right ventricle, but the left ventricle is really looking like it's having some severe dysfunction here. We don't see a lot of wall thickening or approximation here. So moving on to our next view. What do folks think about this view? Which view is this?
It looks like a peristernal long to me that's not really contracting very well or running, shall I say.
Yeah, you're right. This is our peristernal long view. We do have adequate depth here. We can see the descending aorta here towards the bottom of the screen. But this is a pretty foreshortened view. We can tell that it's a bit foreshortened because we're seeing the chordae of the mitral valve in the screen there. And when we're foreshortened in a view like this, it can artificially improve the appearance of the left ventricle function because it appears like we're having more wall thickening than we actually are. We could optimize this image by rotating a bit more. I would say though, even in this view, it still doesn't look like the left ventricle is squeezing particularly well. Because we can see that descending aorta, we don't really see, we don't see effusions. So if we saw some hypoechoic black fluid above the descending aorta here, that would indicate a pericardial effusion. If we were able to see it below, that would be more indicative of a pleural effusion. We don't see either of those. We can't really assess the right ventricle function here in this view, though we do see it up there. And it looks a bit bigger than what I would normally expect. Those were my main findings from this view. And then here is our next view. Just to keep the theme going, can someone shout out which view it is we're looking at here?
Parasternal short.
Yeah. So this is our parasternal short view. It's likely a little under-rotated towards the end of this video here. So you can see the papillary muscles coming into view, and they appear a little uneven, which would suggest that we're a little under-rotated. We also note a little bit of flattening of the interventricular septum at that point at the end of the video there, which would also be consistent with being a bit under-rotated. So it's not an ideal image, but it's still, we can still get a lot of information from this. So looking at this left ventricle, we can see again, not much wall thickening, and we don't see wall approximation. So this is a left ventricle that's really struggling. We don't have a clear view of the right ventricle in this view. And I would say just based off the fact that we're not rotated perfectly, we can't get a perfect sense of how the interventricular septum looks, but we don't see any obvious flattening, any D sign there. All right. And then I know we have a bunch of ultrasound experts on the call, so I know that folks know which view this is. Does someone just want to call it out?
Apical 4.
Apical 4, yep. So we have an apical 4 chamber here. We can really see the right ventricle a lot better in this view than we could see in our others. And then looking at our ventricular function, again, we see that left ventricle really struggling. We can see the right ventricle next to the left. The left ventricle is still the apex forming ventricle, which is normal, so that's good. It's really hard on this POCUS to qualitatively assess the right ventricle function as well as we can with the left ventricle. It does seem like the right ventricle is moving a bit more than the left, but still potentially some decreased function there in the right ventricle. And then we can see our valves here. We have the mitral valve that's pretty clear, and then we can see the tricuspid valve a bit as well. But to really assess valve function, we would want to put some color Doppler on it. So here is our apical 4 chamber view. with some color Doppler.
Megan, before you move on there,
Yeah.
I just wanted to highlight one other important thing, which is that, if you don't see the endocardium of the chambers well, it's hard to make a comment on function. So, here you have like a beautifully aligned image. It looks great. It's a bit RV focused, but it still works. But we can't really see the internal walls of the left ventricle, not the same way you saw them in your other three views. So I just kind of wanted to share that with the group. Now we've got, a lot of people here who do ultrasound a lot and know, but you have to be a little bit cautious if you can't see the endocardium in commenting on function, because sometimes it may look like it's not moving well, but it's only because you can't see the internal edges of the cavity. You have three other views that tell you that that is not the case, that the patient has LV dysfunction that's pretty significant. So that's good. But just to say that if this was the only view you would have, you'd have to probably try to get a little bit more information.
Great. Thank you. Okay, great. Moving on to this image with the color Doppler. So we have this over the mitral valve here. And we can see some mitral valve regurgitation. The things that tell us that it's regurgitation is during systole, we're seeing this jet of fluid. We know that that's going away from the probe because it's blue, but just want to shout out that if you ever can't remember what the directionality is by color, there's always this nice little legend up in the corner there where that arrow is pointing. So we do have some mitral regurgitation here. We can also see a little bit better on this four chamber view, some possible left atrial dilation, so some chronic remodeling in this patient. We did do a similar color Doppler over the tricuspid valve that I don't have in this presentation, but we didn't similarly see tricuspid regurgitation. All right, and then so conclusions for this case, qualitatively, our POCUS showed severe left ventricle dysfunction, likely reduced right ventricle dysfunction. Her formal workup showed severe biventricular dysfunction without a clear or without an inflammatory etiology. So she actually underwent a PET scan to assess for a possible inflammatory cause. I believe her LVEF was determined to be 17% and her RVEF was determined to be 18%. So definitely a heart that is having a hard time. She underwent placement of a biventricular CRT-D for a widened QRS. It was about 145 to 150, and then a left bundle branch block. And she was actually able to be discharged home 3 days after placement of her pacemaker. So she overall was doing pretty well. Unfortunately, even though she had such poor function of her heart, she was not a candidate for a heart transplant because of not having the financial resources to be able to take care of aftercare with a heart transplant. So hopefully that pacemaker is helpful for her. Any questions or comments about our first case before we move on to our second?
No, I just wanted to just highlight something you said that's really important, which is that oftentimes when the left ventricle is not doing well and you're just trying to compare the right to the left with your eyes qualitatively, it's good to remember that even if the RV looks like it's doing a little bit better than the LV, that the LV is not good. So, that often means that the right side isn't doing well as well, which is what makes kind of qualitative assessments of the RV challenging. So I think that that was a really important point that you highlighted and something people should really take away from this. And also just to say that, we kind of are able to grossly get to some important information, which you did from doing your point of care ultrasound. So I think this is a really awesome case, and I'm glad the patient was able to get the care they needed.
Thank you.
Yeah, I also just want to, on the same line, I think we talked about this. I scanned this patient with Megan, is that sometimes, when we look into, qualitative assessment of the left ventricle, we look at wall thickening more than wall movement, because if we have a normal right ventricular function, the left ventricle can be moving along with the right, but there is no wall thickening. And we went over this over and over again because sometimes it's difficult, especially when you're starting to understand the difference. But she had amazing windows, and we're very happy when when she agreed to let us scan and when we put the probe in, because it was really, really easy to obtain and to diagnose.
Thank you. All right. Moving on to our second case. So moving over to Harborview, this is a 21-year-old with a history of opiate use disorder who initially presented in hemorrhagic shock due to a duodenal ulcer that was complicated by a perforated viscus. Now status post an XLAP. His hospital course was complicated by hypoxemic respiratory failure due to ventilator-associated pneumonia, acute respiratory distress syndrome, and mucus plugging. By the time that I saw him, he actually had been extubated and was on high-flow nasal cannula. He had a chest X-ray that morning that showed bilateral dependent consolidations, greater on the left than the right, and then a moderate left pleural effusion. Because this patient's pathology is primarily on the left, we're going to focus on his findings on the left side today. So when approaching lung ultrasound, there are a few different ways that you can do it, but my focus on this rotation and what I think is important when folks are learning is utilizing a systematic approach so that you're getting the same views every time. One method, which is the one that I've been using, is to get 4 views of each lung. So you're looking at the mid-clavicular line, upper and lower lung, and then the mid-axillary line, upper and lower lung. So you look at 8 total images bilaterally. So this is the patient's left upper lung at the mid-clavicular line. We have this image here. This is in M mode, so motion mode. And we can see here this sandy beach sign. So that indicates that we have good lung slide, or that we have lung sliding. So we don't see a pneumothorax here. And then you can also see in the upper part of this image here, these B lines. So I'm going to actually move on to the next slide so we can see this a little bit bigger, but we have these B lines, these comet tails that are coming down right here. And that is an indication of an interstitial process, which we know this patient had pneumonia and acute respiratory distress syndrome. And then one thing I wanted to point out here was the pleural line. And so just a quick review here. Can someone shout out to me which of these, A, B, or C, is our pleural line?
C.
C, yeah. So C is our pleural line. So it's that nice hyperechoic bright white line that indicates the meaning of the parietal and visceral pleura. And so those B lines actually we see those artifacts coming off of the pleural line there. And usually our pleural line is a really nice and smooth, crisp line. In this patient, you can actually see that it looks a little bit ragged. So that would indicate to us some subpleural consolidations. So again, just an indication of the interstitial processes that he has going on here. And one other thing I wanted to call out, if you do see those B lines, that is also a sign that you don't have a pneumothorax, because you won't have that pleural line that those lines will be refracting off of. Okay, and then this is our next image. This is the left lower lung at the mid-clavicular line. And we see a lot of interesting.
Megan, I'm sorry. I need to correct something you said. And sorry, I was on the train, so I couldn't participate in anything. But it's not so much that you're not going to have the pleural line, but you're going to have air in between the pleura, which doesn't allow you to see. So that's really what the issue is, of course, with a pneumo. You won't see anything happening underneath. It's the air.
Right. Okay. Yeah. Thank you for that that clarification and that refinement. Great. All right. So this is our left lower lung at the midclavicular line. So we can see, I'm going to pause this here. We can see this hypoechoic black fluid here. That's the start of our pleural effusion that had been seen on chest x-ray as well. One of the things that I think is really interesting about this view is that you can see as this patient takes an inspiration here. So we can see our pleural line there, and we can actually see A lines, these reflections of the pleural line. They're nice and equally spaced, and they're a normal finding in normal lung. So we have this spared area of normal lung that we can see coming in and out of view as the patient takes an inspiration. And then there's an area here where if we pause the video there, we actually have a shred sign. So you can see this jagged line right here. And that shred sign is the irregular border between subpleural consolidated lung and normal aerated lung. And it's very cool to be able to see this. We would expect the lung that interfaces with that pleural effusion to have consolidation, but we don't always get this shred sign when we're looking at these pleural effusions. So a lot of interesting findings here on this image.
Yeah, I would say like this is such a cool lung ultrasound because even here as the lung slides over, you see right there kind of how chewed up the pleura is. And then once again, you get another shred sign with variation in the way that the lung is appearing. This is pretty typical of a mnemonic process. Or, if there was an infarct or something like that, some intraparenchymal process, you would see these signs. So it's really interesting to be able to see it on an image. You don't get it often.
Awesome. And then our final image here, this patient wasn't really tolerating me getting the mid-axillary upper lung view. He didn't like the probe in his armpit, but we did get a good left lung mid-axillary view in the lower lung field. And here we can really see that pleural effusion. The movement on the screen is just trying to give you a good picture of the diaphragm there. But we can see that jellyfish sign, so that lung that's just swimming around in that large pleural effusion there. So pretty significant pleural effusion on this patient. What I think is interesting is that it is a significant pleural effusion. It was not noted as being this large on our chest x-ray. So we were actually able to get a better appreciation of the size of this pleural effusion qualitatively with ultrasound than we were on our chest x-ray. Which
Megan, though, yeah. I do have to say, it is very hard to quantitate it with a linear probe there. You do not have a lot of depth because that's part of the issue. So if you use a curvy linear probe, and I know you said he didn't like things in his mid-axillary line, but you could often get this so easily. It's much easier to quantitate the amount of pleural effusion using that probe rather than this linear one.
Yeah, awesome. That is a perfect segue. Thank you so much. I actually wanted to talk about that. So like you mentioned, I was using a linear probe for this because I wanted to. The linear probe, a higher frequency probe, has good axial resolution, so we can see things on top of each other well with that probe, and it's good for assessing for lung sliding. But yeah, you're right. I could have switched to the curvilinear probe. You can even do these lung ultrasounds with a phased array or a cardiac probe. So both of those offer a lower frequency, lower resolution image, but deeper penetration. And the cardiac probe also has the benefit of a smaller footprint, which can make it easier to visualize structures through the rib spaces. And we can use any of these probes for a lung ultrasound, and they each have their benefits and limitations. And if we did use a curvilinear, you can, like Denise said, actually estimate the size of a pleural effusion. And one way that you could do that is with the Balick formula. So this is a relatively straightforward way of being able to estimate your pleural effusion volume. This was a protocol that was published in 2006. The way that they did it for the study is the patient's positioned supine with the trunk elevated to 15 degrees. You use a curvilinear probe and you place it in the posterior axillary line, and you're looking at a transverse section with that probe, and you want to measure the distance in millimeters between the parietal and visceral pleura and at end expiration. So that's you get the maximum distance there if you get it at end expiration. And then the formula itself is very simple. You just take that separation distance that you measured and you multiply it by 20, and that gives you an estimate in milliliters of the volume of that pleural effusion. It can be really helpful for determining if the patient potentially needs a thoracentesis to drain that pleural effusion. One thing that I did note when I was reading the paper is if you had a particularly tall patient, it can actually underestimate the volume of that pleural effusion. It didn't give a specific height where you start to see that, but just something to keep in mind if you're using this in your practice. And this image is from that paper. This is not an image that I got, just to clarify. So as far as what happened with this patient, so we've talked a bit about our limitations. This patient, not surprisingly, given all of his lung pathology, was not able to tolerate lying flat. So this exam was performed with the patient semi-upright. We could have used a probe with a lower frequency to better assess the depth of the effusion. This patient did still undergo an ultrasound-guided thoracentesis the next day, and they drained 825 milliliters of fluid. That was consistent on testing with an exudative pleural effusion, which is not surprising given his ongoing pneumonia. And his consolidations continued to improve over the next few days with IV antibiotics, and there wasn't any notable reaccumulation of pleural effusion on chest X-ray over the next few days. All right. Any questions or comments about this case? Before we move on, I have one more case for us.
No, I just want to say that's so gratifying that you guys, that they were able to go in there and remove so much fluid, and they used your POCUS, right?
Yeah, they did. I didn't know, but at the time they or I didn't know it at the time, but they actually used those findings to sort of guide their decision to take the patient for a thoracentesis the next day. So it was nice to see it in action. All right, awesome. So final case here today. Going back to some cardiac, we have a 72-year-old female with a history of chronic pain secondary to mastectomy, atrial fibrillation, prior CVA, and an aortic root aneurysm who had a biobental and left atrial appendage clipping, now with concern for a paravalvular leak, which if you think about the biobental, so this is an ascending aortic graft with an integrated bioprosthetic aortic valve. So it's all one piece. So having a paravalvular leak would be really unusual. So I evaluated this patient in the CT ICU on postoperative day 3, and at the time of the exam, the patient was in normal sinus rhythm. So looking at her prior formal TTE, they noticed some left ventricular hypertrophy with an ejection fraction of 55%, some abnormal septal movement, which is not surprising given that this patient had been on cardiac bypass recently. And then they did note this abnormal continuous flow along the base of the anterior leaflet of the bioprosthetic valve, and then abnormal thickening of tissue anterior to the biobental. And then she had a moderately dilated right ventricle with mild systolic dysfunction, and then moderate tricuspid regurg with a severely dilated right atrium. And what I really like about this case is it demonstrates some limitations of POCUS and TTE. So this is our parasternal long image. This patient was very tender, so she has a history of chronic pain where her mastectomy was, which was on the left side. And she also had acute postoperative pain. So she wasn't really able to tolerate moving and repositioning to improve our windows. And she didn't tolerate very much pressure from the probe. But as you can see, the ventricles are really quite cut off here in this image relative to what we would normally like. But what you can see is this shadow where that arrow is, which is an artifact from the prosthetic valve and shows something that we know happens, which is that you can have a lot of image interference and dropout with those prosthetic valves. It can make imaging with the TTE quite difficult. So it's a good example of that. And then this is our parasternal short view at the level of the mitral valve. We can appreciate better in this view some of that left ventricular hypertrophy, and we can also appreciate some of the septal dyskinesis. So with the cardiac bypass, we can see a transient alteration of the electrical conduction of the heart. So not unusual to see that septal dyskinesis, but interesting to see it here. And then looks like a potentially enlarged right side of the heart there. I was able to, from this parasternal short view, kind of scoop up to get a better view of the aortic valve than what we had on our parasternal long view. So this is again our parasternal short now at the level of the aortic valve there. We do have better visualization of the aortic valve, but you can still see some really significant artifact and shadowing from that prosthetic valve in this view. But given what we had heard about the possible paravalvular leak, I wanted to put some color on this. And we got this finding, which is really quite interesting, I think. So again, we have our little bar here to help explain the colors to us. And so we see this sort of continuous eccentric flow, primarily that's most pronounced in diastole, and that blue flow would be consistent with it going away from our probe. I don't know that this is truly going directly away from our probe, but at least some component of it is going away from it. And just given how significant this artifact is here from that bioprosthetic valve. Don't know that we have a clear visualization of the location, but it's definitely an interesting abnormal finding that I would say we're not able to fully appreciate on TTE in this particular postoperative patient. And then this is my final image for this patient. This is an apical 4-chamber. Was unable to obtain an apical 5-chamber view of this patient, just given her general intolerance and tenderness. It is white foreshortened. We could improve this image by sliding laterally. In this particular patient, that was a very tender spot for her and she didn't really tolerate it. But we can see that the right atrium, though it is foreshortened, does appear to be quite dilated, though this is a poor quality image for really assessing the chambers.
Can you go back to the previous image? Is that
Yeah.
parasternal short axis?
This is a apical.
No, the previous one.
Yes, let's see. This is a parasternal short.
Yeah. No, I was just, I mean, like you came into, so I looked at this patient's pre-op transthoracic, and also they ended up doing a CTA because unless there is a problem with the graft, which they would have seen something post-op because you see this right away. And I look at a TTE as well, the TE post-op with the fellow. It kind of looks like it's inside the sewing ring. If you actually see like that, see how there's the widest, that's where the valve, like the ring of the valve inside the graft is. And I asked them, why? Because you always have to ask, like, why did they do this? Because why did we do a TE post-op? Right? What were they looking for? And that, if the patient was with hemolysis is one thing, right? Because then we very worry about perivalvular leak being clinically significant. But I asked them, they said, well, she's not doing great. So then we did a TTE, and then they saw something that maybe looked like, even though we know it's not really possible. If you look at the way the bento, the graft is done, unless there's a manufacturing problem. And then she got a CTA, which is like, cannot rule out, which doesn't really mean that it's obvious and she has it. So I'm not sure. I really like this image, but I do think that it's, it's happening inside, like in the coaptation of the. See if you pause that, you can see the 3 leaflets, and I think it's between the I don't know, right, left, and none. Right.
Yeah.
Which wouldn't be unusual to see. But again, this is kind of a puzzle, and because you remember you came to the OR, and then Burke was like looking at us, he heard us and said, please don't tell that patient again that she has a perivalvular, because she doesn't. So I'm not really sure if that's what it is, but it's definitely worth the discussion, because I think that a lot of people don't even understand. If they don't do cardiac anesthesia, they don't even understand how what's being used when we do a bento. And I know as a fellow, there was a surgeon that asked me, do I have any perivalvular leak? And I was like, he's like, it's impossible. So then it kind of like prompted me to read and figure it out how the graphs works. But it was a great case. Thank you.
Yeah, thank you.
I was just going to highlight, I think what's an important takeaway kind of for the all-comer point of care ultrasound user here is that when you're evaluating something in short axis like this, where blood would basically be coming at you, like straight out at you, and your Doppler assessment is exactly perpendicular, it's going to underestimate whatever it is, whatever pathology that will be there. So typically you're not going to see too much, or if you do, it's not going to be the full strength of what's going on. But I think what is curious about this image, and is probably why it pursued them to get more and more information, is you see, kind of clear flow that is very distinct in color, that tells you it's going in a specific direction, and that direction is kind of down, which just tells you that whatever is happening here, what you've caught on this image, you may not even see where it started, but what you've caught is a flow that is, you know, kind of in line with your Doppler assessment, which means that it would be eccentric, right? Just because you're seeing that the flow is going down to the bottom of the screen as opposed to like coming out towards your face. So I think that's probably what clued them into the fact that something was definitely not right. And I agree with Dr. Nook that, you know, it's hard to tell where it is originating from, because that's extremely hard when you're at a 90-degree angle flow from your assessment. But clearly, there is pathology here that's eccentric, which is probably what made them worry about there being something really abnormal going on with the valve.
Awesome. Yeah, thank you for that addition. Okay. So just some conclusions from this. I think that this is a good demonstration of some of the limitations of POCUS and why it's good that we still have transesophageal echo available to us to provide a better assessment. So this patient had a lot of difficulty tolerating the exam. They also, on her follow-up cardiac CT, saw a small volume pneumomediastinum. And so you can imagine if there's air between the probe and the heart as well, that can make your imaging difficult. And then we, of course, had the artifact from the bioprosthetic valve itself. So as amazing as POCUS is, it's not always going to give us all the information that we might want and need. This patient did get a follow-up cardiac CT that did show a possible small paravalvular leak of the bioprosthetic valve, but per cardiothoracic surgery, the leak is not clinically significant if it is there. And this patient was able to be transferred to acute care on post-op day 6. All right, and that's my last case that I have. Thank you everyone for listening. Any other questions or comments?
I just wanted to say thank you so much, Megan and Benny and Kapil, I think, for, you know, going through the cases and scanning, and for you taking the time, Megan, to present all of these really interesting cases to us. I think there's always something to learn. And we learn so much, even when sometimes, like you said, the images are not perfect. That teaches us a lot too. And I think as you grow and you evolve, you'll sometimes find that teaches you more than when they are. But this was a really great presentation. I think we learned a lot. Thank you for presenting the Balick formula and how to kind of estimate thoracic fluid volumes or to the team here. And I just really hope you continue on your POCUS journey. And maybe we'll see you back in the future for more interesting cases.
Yeah, thanks. I also want to thank Tony. He helped